Hi, I'm Jen Brewer, nurse specializing in wound ostomy and continence, and I teach people about the wonderful world of wound care. Today I'm sticking with my time series. We're doing tissue still, and we're going to do slough. This is one of the devitalized tissues that we do see often in wound care that can be, a little disconcerting to actually determine what type of slough it is and how we're going to treat it. So I'm starting here with the normal type of slough. This is actually a full thickness graft that has the epidermis and the dermis taken off, and you're actually seeing adipose tissue. This is fat, or the underlying tissue that, again, in this area is not quite common. This is a full thickness graft, so this was taken from the stomach and then put in here to fill a deficit post-surgery. So this is just a really great example, though, that you're seeing sometimes in a wound base, and you're going, oh, what do I do with this? Because again, remember, we want that lovely red granulation tissue, the one that's forming those capillaries and going to be the building blocks of new tissue. So again, this is what adipose looks like. So again, it's also loosely termed slough, and this is kind of an adherent slough that's on the wound. There are other examples of adherent slough. One of them looks like this. This is biofilm. Biofilm is actually a polysaccharide extracellular matrix, which is a really huge term for the bacteria within the wound having a party, and they've built an encasement around themselves because they really want to stay there. These are party animals, and it makes it really difficult in chronic wounds to actually get rid of. So again, this is another example of very adherent, really tight slough that is really attached to the wound base. So loose adherent slough kind of looks like this. You can see right around the edges down here how it actually looks like it can be easily removed, which it is. And when we do some conservative sharp debridement, we can actually cut and remove that slough from the wound. It actually helps things go a little bit faster. So again, to be able to identify the difference between these structures, I also want to talk a little bit about what are we going to do for them. So again, this wound is one that I'm definitely going to look at trying to do some sharp debridement so we can get down to the base of the wound, and then we'll likely fill it with an alginate. Again, if there's odor, because we are seeing some necrosis, we might use a silver alginate as well, or a silver hydrofiber, just to absorb some of the fluid that's going to come off of this wound. Now I'm going to go back to the biofilms. So again, biofilms are really adherent, and they're really difficult to get out of the wound. Yes, we can do some sharp debridement. I do that actually quite often in my clinic. However, when this patient, leaves the clinic, they still need a way to prevent this from coming back. This is where I use iodosorb ointment quite often, because again, it is a chemical debriding agent, and it can help to continually remove that biofilm from building on the surface level. Again, in past videos, I've talked about how iodine is one of the smallest molecules. It can penetrate bacteria much better than some of the others. Not that a silver is not something that we couldn't use, but when the biofilm is chronic and it keeps returning, iodosorb is often one of the best ways to get rid of it. So continuing on with some of the other things that sometimes are seen as slough, but they're not. So number one, this is actually gout. This is tophi. So tophi are these little white nodules that fill with uric acid. Gout happens when our uric acid levels are very high, and they accumulate in the joints. So this one is actually a large ulcer that's erupted, and a lot of this white cottage cheese type material has come out. And again, we're looking at slough in the base of the wound. Now, when we have this looking as this does, sometimes it's actually best to remove some of the tophi. So I will actually get one of the surgeons to do a surgical excision and remove this. If that's not the case that we're doing, we're still going to want to use a product that's going to provide some autolytic debridement, such as a gelling dressing, to absorb the fluid as well as remove the remaining slough in the base of the wound. Now, this is another one that's a little trickier, though. So everyone says, oh, it's yellow slough, but this is actually a bony structure. Bone, when you find it in a wound, actually makes a very distinct sound. When we're using our probing cotton tip applicators, you'll actually can make a scratching sound over top of this. So that's how you're able to indicate that it is bone. Bone, there's nothing you're going to do to debride. If you actually try to remove it, it's going to bleed quite easily. One thing if it's a large piece of bone like the calcaneus in this photo, but it's different when there's our small chips. Those chips can be easily removed, but please be aware that they can actually cause quite a bit of bleeding if they're adhered to the surrounding tissue. Oh, we're not going to do this guy, but anyways, we'll start with this one. So this is obviously some slough within a wound too. You're actually seeing adipose tissue. This was a patient that had dragged his foot across a carpet, and does have some adipose exposed. So in this case, because we have about 50% granular tissue and 50% adipose tissue, we still want to look at something that can autolytically debride and absorb the fluid, as well as maintain that moisture balance. So definitely it's something that we'll also look at some of the callus, but that's a whole other video. We want to be able to autolytically debride this as well, so by providing that moisture balance close to the area, because again, ointments like iodosorb or even the Santal, it's an enzymatic debriding agent. Those can be useful to get rid of the slough. But again, once there's greater than 50%, sometimes they'll start to back off. I usually wait till about 80%, so that we have good granular tissue within the wound, and then rely a little bit more on the autolytic debridement. So another structure that we can find quite often in a wound is tendon. So this looks just like slough, looks like the adipose, but it's not. It actually has striations in it. And so if you look at it closely, there's like this little weave in it. That's because there was adaptic over it to protect it. But again, they're very long and linear lines that are within the tendon itself, and that's how you're able to tell if it's adipose tissue or fat, or if it's actually tendon. So tendon is not something that I actually want to debride. It is something I want to keep moist. So again, that's why you're seeing this over, because we did have some adaptic on it. I've used a product called Bactigra to just help with the moisture of that, because if that tendon dries out, it will actually snap and you'll actually have less tendon left there. So we want to try to not debride tendon unless we have to. So there's a little piece here, but we're going to just try to keep that nice and moist so that it does stay healthy and that we are able to fully close the wound. Again, so this is another form that sometimes is considered slough, but again doesn't require debridement. So this is a fairly typical venous leg ulcer, especially one that's been chronic in there for a long time. So again, we're looking at, probably 40% granular tissue within the wound base, and the rest does appear to be adipose or slough. There definitely can be a mixed biofilm in here. So it is, again, one of those wounds that I do want to try to autolytically debride that. The patient is most likely not going to tolerate me doing any conservative sharp debridement, like taking a scalpel in and cleaning that out. So again, that's something like iodosorb, sometimes a gelling dressing. It really does depend sometimes on the amount of drainage coming out. And last but not least, what do we do with when they just got little witty bit of slough in there? Well, those are ones that I can definitely rely on my gelling dressings to not only absorb the fluid, but it will autolytically debride this last little remaining slough that's within the wound. And so it isn't something that I get too concerned about. So those are the main wounds that I wanted to show today and about slough. And again, just to remember, most of the time it's devitalized tissue. Again, be aware if it is bone or if there is tendon that's actually present. And also, again, there are lots of different products that we can use to debride. I've only mentioned a few, but those are some of the ones that I use most often because they're actually quite readily available to nursing. All right, very Merry Christmas. Thank you very much. Like and subscribe. Let me know if there's anything more we can teach you about.